Welcome everybody. Today we are talking about pneumonia. Pneumonia is inflammation of the lung parenchyma. The British Thoracic Society defines community-acquired pneumonia in patients which are admitted to hospital by signs and symptoms which are consistent of lower respiratory tract infection. So these signs and symptoms are cough, shortness of breath, tachypnea, pleuritic pain. It means when the patient breathes in or cough, they will have chest pain, fever, new focal signs and symptoms of on chest examination. Neuroradiographic shadowing, which are consistent with the pneumonia and not explained by other pathology, example pulmonary edema or lung infarction. So if you come to the causes of pneumonia, the commonest cause of pneumonia are bacterial in adult, most commonly Streptococcus pneumonia, but it might be due to any other bacteria. Viral, influenza A, B, respiratory syncytial virus, coronavirus. We also have the atypical pathogens. The atypical pathogens, most commonly Mycoplasma pneumonia and Chlamydia pneumonia, and also Legionella. So these may cause atypical form of pneumonia. So atypical ones, they usually characterized by being difficult to diagnose because they have various signs and symptoms before developing cough, and usually sometimes of them they have dry cough. They're also sensitive for specific antibiotics, example macrolide like azithromycin, tetracycline, fluoroquinolone, example levofloxacin. Usually they are not responding to beta-lactam because they don't have a wall. Severity of community-acquired pneumonia can be assessed in adults by using KERB-65 score. If the patient have confusion, urea more than 7 millimole per liter, respiratory rate more than 30 or equal to 30, blood pressure less than 90/60, age more or equal to 65, each one they will get as one score. And I have to notify you that the urea is in millimole per liter, so to change it to milligram per deciliter, you have to multiply it by 18. If the score is 0 or 1, it is low risk, so you can discharge the patient on antibiotics, can be discharged and treated at home. Score 2, you have to consider admission to the hospital because they are at increased risk of death. Score more or equal to 3, they have to be admitted to the hospital. And if the score is 4 or 5, it means it is very severe and they need usually ICU admission. The investigations that are done for the community-acquired pneumonia, the most important one is chest X-ray. However, chest X-ray is not needed for all the cases, but it is all the cases which are admitted should have a chest X-ray. But if it is mild pneumonia and you are sure in your diagnosis, no need to do chest radiograph. Also, if the progress following treatment is not satisfactory or the patient have it as at risk of underlying lung pathology, example cancer, you have to do a chest X-ray. Blood tests, full blood count mainly to see white BC, urea to assess the severity of pneumonia, electrolyte, liver function test, C-reactive protein as a baseline measure. It's better to have these investigations. SpO2 pulse oximetry should be done in person for all patients. And if SpO2 is less than 92, according to the BTS guideline, you have to do also arterial blood gas analysis. The microbiological test is not needed for all the cases. They are usually needed for severe cases, moderate to severe case. Example, blood culture, sputum culture, pneumococcal urine antigen test. Even these two, they don't need it in most of the cases, only in specific circumstances when you are in doubt. Sputum for Mycobacterium TB is done for patients who have persistent cough and they have signs and symptoms like malaise, night sweat, weight loss, And also risk factors of TB like social deprivation, specific ethnic group, and also elderly patient. Ethnic group example in India. Treatment of community acquired pneumonia in the emergency department, you have to concentrate on oxygen. Oxygen, if low, you have to give to a level of saturation, to maintain the saturation between 94 to 98%. However, if the patient is at risk of hypercapnic respiratory failure, example a COPD patient, you may maintain the oxygen saturation between 88 and 92. IV fluid for patients with evidence of fluid depletion, antibiotic therapy guided by local microbiology policy, prophylaxis of VTE. If the patient is bedridden and not mobile, you can give them low molecular weight heparin. Low molecular weight heparin, the one which is commonly given in our hospitals is enoxaparin, also call it Clexane. The Clexane dose for prophylaxis is 4,000 units once daily subcutaneously. Critical care involvement for moderate to severe pneumonia. Coming to antibiotic. So which antibiotic do we give for patients with pneumonia? We depend on the BTS guideline, which says that for low severity pneumonia, you may just give an amoxicillin 500 milligram 3 times daily orally. If they are not accepting amoxicillin due to allergy, so you may give doxycycline or give them clarithromycin or even azithromycin. For moderate one, you may give amoxicillin but increase the dose to 1 gram plus a clarithromycin. So you'd give dual antibiotic, amoxicillin or amoxiclav plus clarithromycin. Alternatives to it are doxycycline or levo or moxifloxacin. For the high scoring, for the patient with severe, you usually admit them and give them co-amoxiclav in doses of 1.2 3 times daily intravenously, plus azithromycin or clarithromycin. So again, dual antibiotic, but you have to start with IV. The alternatives are benzyl penicillin plus levofloxacin. Sometimes you don't have co-amoxiclav, so you may instead give third generation cephalosporins, example ceftriaxone. We give 1 gram by 2 IV. So what if the patient improving after a few days? So what is the duration? The duration now they change it to 7 days. If they are severe, you may extend up to 10 to 14 days, but usually 7 days of antibiotic is enough. What if the patient improved, a severe one improved after a few days and the patient is on ceftriaxone? For example, after 3 days, you want to change ceftriaxone. You can change them to amoxiclav. According to the BTS guideline, you can change them to amoxiclav 625 milligram 3 times daily for the remaining days. But levofloxacin, you have to continue on levofloxacin tab. So these are the key points. The community acquired pneumonia in patients admitted to hospital, they have to have signs and symptoms of acute lower respiratory tract infection plus new radiographic shadowing. Streptococcus pneumonia is the most common cause of community acquired pneumonia. Chest X-ray should be performed for all patients which are admitted, but not necessary to do for mild cases. CARB 65 score can establish the severity of pneumonia, and you can decide whether you discharge the patient or you admit in the ICU. Thank you.